Yes.
Professor Botros, please, can you give us your opinion and your conclusion? And afterwards, Professor Casper will sum up and give us his idea about a research that we can do in EFRI, and Professor Botros can share, and then we will close afterwards. Please, Peter.
Thank you so much, Dr. Hassan, for this wonderful opportunity. Thank you so much for this wonderful opportunity. It is first mood elevating in the era of Corona, because all of us are stuck alone, and even when you go to the office, it doesn't feel like an office anymore. So it's wonderful to see friends, you and Bob and Mohammed and everybody that's in the audience. I truly enjoyed them. So thank you for both the great scientific effort and the detail that you took, as well as giving us this wonderful opportunity. Hopefully many more to come from EFRI under your leadership. I also want to thank IPSA for a great job. Don't bite at them. They really did a good job. I mean, it's very difficult to get 10 guys to speak, and so all that. So basically, I've been asked by
voice.
You hear me well? I have been asked by Professor Hassan for the easy and difficult task. The easy task is just to give my overview. Do not go into paper by paper or analyze or critical. Just give an overview what really is the daily experience. The difficult is that many of it has, like all of us, will have been guided by feelings and our previous performance on the last year. So I would like in the next 3 to 4 minutes to summarize to all of us in this audience what variables have we done and what is really has been our personal experience with that. So the two biggest protocols that have been used have been an agonist protocol followed by estrogen and then progesterone, or straightforward estrogen and progesterone. Sometimes the agonist is used for more than 1 month, as Professor Casper alluded to in endometriosis. Actually, one of the first people to start that was Sam Marcus from Bourne Hall in the 80s. Actually, is a paper that had Bob Edwards on it, that he gave decapeptyl from 2 months to 7 months prior to, that was fresh IVF, not frozen IVF. And he showed that actually after 4 and more months, there was a significant increase in pregnancy rate. And this was from 89, and his paper was published in the 90 or 91 at the time. So this was one of the opening things, and then there were meta-analysis for that after only 3 trials. So definitely there is a place for multiple GnRH agonist injection. The number of months is not known because, like I mentioned, he showed an increase in pregnancy rate only after 4 to 7. But we use also two, and we as Dr. Casper mentioned, and we replace on the 3rd time. So this is the first thing as far as the length of GnRH cycle before. Where do we do GnRH cycles most of the times now? No, now it is the minority. We started doing it in 1989, and we probably did it for like almost 30 years. Loop on day 21, and then down regulation, then estrogen and progesterone. Now we use mainly estrogen and progesterone. The many questions to be open. When do you start the estrogen after the H agonist? We started it anywhere from 1 day to 120 days, or there are papers up to 120 days. And there were many times that we were traveling or that the batch didn't happen, so we used 2 to 5 weeks of gap on Lupron on a low dose before starting.
Voice, Peter. Voice
is not good. Let me try a different technical way and use the AirPods and see if they improve that.
It's absolutely fine now, Professor Botros.
All I did is I moved in my room.
That's fine. Yeah. I can hear you finely now.
Better now?
Yes, yeah. Much better.
Okay. At all or worse?
It's absolutely fine, but however, we can, yes, okay. We can see you right now.
Okay. So this is the issue is, when do you start the estrogen? Variable. There is no really scientific evidence of a length of time on GnRH prior to initiation of estrogen. How long the estrogen? The typical that has been used has been 10 to 14 days. You've shown papers that showed a lower pregnancy rate below 5. I don't definitely recommend lower than 5, and probably 10 to 14 days would be optimal use of estrogen. The point of initiation of progesterone is more debatable, because it depends on all the issues that we discussed before during this evening, from thickness to appearance to many things as well. Coming from that to the new estrogen progesterone, one of the things that definitely happened, it was interesting to hear Professor Hassan's opinion that they went from 7 to 6 to 5. So we used to use even less than 5. And we had the pregnancies, and we noticed very high miscarriage rate, and it was just observation. So we moved to 5, then to 6, and then to 7. With 7, it was definitely higher than 6 in our hand, although there is not a single trial that showed that 7 was higher. All the trials shows that 7 is lower. But let me go into some details. What is 7 and what is 6? It really depends on the number of hours. So if you're going to use 120 hours or 144 or between 96 and 120. So 96 is 4 completed days. 120 is 5 completed days. 144 is 6 completed days. So if you're going to start, say, do an embryo transfer on a Friday morning, do you start it the previous Sunday or Saturday before? And we used to start it Sunday night. Then we started Sunday morning, then we started Saturday night, and many times Saturday morning. And we now swing between Saturday morning to Sunday morning for Friday morning or afternoon transfer. It doesn't really matter exactly, is it a transfer at 10 in the morning or 4 in the afternoon? I think that is more theoretical, because if it is that sensitive, then our odds of pregnancies are very much lower. But this has been definitely the hands-on experience as far as that, or the personal experiences as far as the progesterone. Most of the times now we use IM progesterone, and we used a lot in the past, but more in fresh than in frozen, like vaginal progesterone, and with IM every 3rd day, and then we tried in the frozen, vaginal and IM in the every 3rd day. With the vaginal only in the frozen, we definitely had a higher miscarriage rate. There is no question. In our end, there was definitely a higher miscarriage rate that is noticeable even by, without having to do a study for that. We have no experience in oral progesterone because, like dydrogesterone or many of the other things, and we have no experience in subcutaneous progesterone, but both will play roles and combination of things, because until now, IM progesterone is a nuisance, as we all know, but effective medication, no question about that. Having said that the vaginal higher levels in uterus and all that, all this is one study in the literature showing that, did a hysterectomy and check the levels and so on. I'm not saying that the study is bad or anything, but this whole concept that and so on was one study, but also was the manufacturers and so on, was like put on every event in the history. So everybody, if you could tell them, vaginal persistence, say, oh, the endometrial levels are higher, or despite that the blood levels are low. Yes, it could be, but this is very, 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 very limited information, to say the least, or to say the best. So at this point in time, we are challenged by many things, including not good endometrium, very thin endometrium, and Bob had many lectures over the years that I attended to address the challenges of really thin endometrium. 4, 5, 6 doesn't change, doesn't budge. You change the estrogen dose. We found the following, that omitting some of the things improved the endometrium. So in one of the patients that just actually delivered at 45, and she was insisting to use her own eggs and so on, and we froze the embryos. The endometrium was most challenging, and one of the things we did, we used to give her Lupron before we canceled the GnRH agonist, and that improved the endometrium. And we used to give her sometimes before birth control, then Lupron, then estrogen. We canceled both, and that had a positive effect. So using the estrogen from scratch is a good idea. Leaving us with a group of patients, the amenorrheic patients, for whatever reason, whether they had polycystic ovaries or whether they had the embryos frozen at the time they were cycling, and you froze the embryos, and now they're amenorrheic. For those patients, we do one of few things. We sometimes just give them a trial runs before, like give them a couple of weeks of estrogen and then maybe some progesterone, let them cycle 2 or 3 times, because many of those, I mean, like we had one very recently. I mean, estrogen, progesterone levels are basically undetectable and endometrium very thin. So if you just go ahead from the first time, you might be lucky, but you can repeat, or you can go through the more standard way. You can give them some birth control, then Lupron, then estrogen, progesterone, or Lupron straight, then estrogen, progesterone. And I'm open to suggestions for those, as of course the experience with them is not as extensive as with others. So I think I would stop and conclude at that and give you opportunity to share your 820 questions. And again, I thank you all. Thank you, Dr. Gibril. Thank you, Professor Hassan, and all the great panelists for giving us this opportunity.
Thank you very much for an excellent overview of your vast experience, as we all know, of course.